Welcome to the third lecture of the Hematology series in preparation for the PANCE or PANRAY. The first two lectures can be found on YouTube by searching for paboardreview.org. My name is Wesley Norwood, and I'm part of Joe Gilboy's PA Board Review team, where we teach and practice evidence-based learning. In this lecture, we will review the pathophysiology associated with those questions most likely to be asked during the PANCE or PANRAY examination. Hematology only comprises about 3% of the examination, but we were going in depth because of the importance that hematology and the vascular system plays in all the other organ systems. If you think about it, no cell in your body is more than a 2-cell distance, so there's no more than 2 cells away from a capillary. When you begin to wrap your mind around that and understand that, you begin to really understand how this affects everything else. A quick review of the homeostasis that is in place. We're going to review the extrinsic and intrinsic pathways. So as we said before, the liver supplies a constant supply of inactivated coagulation factors that are ubiquitous in the bloodstream. Endothelial cells serve a lot of purposes. Some of them are to decrease friction. They're also biologically active, releasing products to keep clotting under control. The GI tract is responsible for absorbing vitamins and nutrients. Some of the important ones that we've mentioned are B12, folic acid, we'll talk about iron, and many more. The kidneys can release EPO in order to increase the red blood cell production in the bone marrow. To get a better understanding or a more in-depth look at this, please see our second lecture. Blood flow decreases the probability of inactivated factors interacting with one another. Inactivated platelets and red blood cells are also ubiquitous to the circulatory system. So, every day our circulatory system experiences thousands of microtraumas due to activities of daily living every day. The analogy that I heard that I really like is eating a bag of Cheetos. So you chew the Cheetos, they're still a little rough, peristalsis takes it down your esophagus, some trauma is incurred during that. Well, what happens? Well, the endothelial cells, there's an insult incurred, the connective tissue is exposed, product is released. What happens? It causes the smooth muscles surrounding that area to spasm, and that decreases blood flow. In order to repair and maintain homeostasis, the circulatory system has a number of ways to deal with these insults. The intrinsic and extrinsic pathways are part of the system. Repair is designed to stay isolated to the site of injury and not cascade out of control into other areas. So what happens is the damaged endothelial cells and the adjacent endothelial cells will release a platelet adhesion protein, and we call that platelet adhesion protein von Willebrand's factor after the doctor who discovered it. And what happens is that special adhesion protein has hooks for inactivated platelets. So inactivated platelets will be able to stick to that. That brings us to the first question: what is the most common hereditary bleeding disorder? Well, you guessed it. It's von Willebrand's factor. And what happens is there's 3 types. Type 1 is the most common, 2 and 3 are the most severe, but what happens is there's a genetic defect in creating the von Willebrand's factor. So what's prolonged? Well, because the proteins will be affected, the bleeding time will be prolonged, and because this is part of the intrinsic pathway, the PTT will be prolonged. There will be no increase or problem with the PT. Now, a note must be made that there's also von Willebrand factor circulating in the plasma, and it does a few things like it preserves factor VIII and does a couple other things. So it's not only this primary platelet plug, but other things that are affected along with this. So the treatment for von Willebrand's factor is desmopressin, which increases factor 8 and also von Willebrand factor. So next what happens is there are vesicles within the platelets that release granules. These granules contain things such as serotonin, ADP, and calcium ions. ADP activates platelets. They cause them to become sticky, create these hooks so that they can stick to the platelets that had already adhered to the insult. So this is where some of the drugs come into play. They prevent the activation of the platelets. Aspirin being one of them, Plavix, clopidogrel, and when platelets are involved, then bleeding time will increase. So if you want to test the platelet function, you order a bleeding time. So some of the times you might see on a test question INR. INR is a combination of both PT and PTT, and the normal range is between 2 and 3. So then more platelets are able to come and stick to the first layer. This is called platelet aggregation. It's called the primary platelet plug. So this is where it becomes a little tricky. So as we said before, the liver releases inactivated coagulation factors. The platelets that had adhered in the primary insult are the catalysts for the activation of these factors. So if you kind of look at these, 7 becomes activated, 11 becomes activated. I think the ones to focus in on are calcium is very important. Factor 8 is very important, especially in the activation of 10 and thrombin. Now, 10 and thrombin and fibrin and fibrinogen, which we'll see in the next slide, are common in both the extrinsic and the intrinsic pathways. So when you talk about the intrinsic pathway, we talked about PTT. Joe likens this to anything given IV or sub-Q, like heparin, streptokinase, urokinase. They work on the vitamin K, but we'll talk about that in a minute. So like we said before, calcium, factor 8, platelets are important in activating factor 10. Prothrombin becomes thrombin. So what that does is it activates fibrinogen to become fibrin, which then creates strands to form a stronger plug. And this is called a secondary platelet plug. I like to think of the fibrin like rebarb in concrete. Causes to become stronger and resistant to shearing forces and trauma. So let's quickly review the extrinsic pathway. So extrinsic pathway is initiated with tissue injury. Tissue factor is released. Tissue factor activates factor 7. Factor 7 also activates 9 and 10. When we want to look at the extrinsic pathway, we look at the PT. Joe likens the PT like PO, anything you could take by mouth. Coumadin, warfarin. Don't get confused, aspirin is not part of that. That affects the platelets. So, if you have a patient who has abnormal bleeding with dental extractions, a traumatic knee effusion, what do you think of? What's most common in 80% of the cases, males greater than females, and the PTT, the intrinsic pathway, is affected. It's hemophilia A. So hemophilia A affects factor 8, and the treatment is cryoprecipitate, factor 8, and desmopressin. So it's the most common. You can have a traumatic knee infusion, and when we talk about hemophilia B, it's not as common, only 15% of the cases. Factor 9 is affected. You can have joint involvement, and that's what differentiates hemophilia A and B from C. C, rarely do you, if at all, do you see any type of joint involvement. Now, hemophilia B, I was always confused. Why was it called Christmas tree factor? Was it because you saw certain patterns? Well, the doctor who described it was Stephen Christmas, and he actually published it in the British Medical Journal in the Christmas edition of that journal. So along with hemophilia A and B, PTT is prolonged. There's no normal bleeding time because platelets aren't affected. So hemophilia A affects 8, hemophilia B affects 9. With hemophilia B, you can have joint involvement, muscle, CNS, GI, genitourinary, and pulmonary system involvement. Okay? Now, hemophilia C affects factor 11, and it affects Jews who are of Ashkenazi descent, and like I said, it could be distinguished from A and B by joint involvement, and you do have a prolonged PTT, and bleeding time is normal, and the treatment is fresh frozen plasma. An important note to make that Joe emphasizes that approximately 50% of hemophilia A or hemophilia B are now HIV positive because prior to 1985 the pooled natural blood product was not screened for it adequately. Okay, now let's look at those factors that are dependent on vitamin K. So in order for the liver to produce some of these factors, vitamin K must be available. So an easy way to remember this is with the acronym SNOT, SN0T. So S stands for 7, N stands for 9, 0 would stand for the 0 and 10, and 2 is another name for prothrombin. So I circled those factors in green, and if you notice, both the extrinsic and the intrinsic pathways are affected by this. Okay, so both the PT and the PTT will be prolonged when vitamin K is brought into the picture. And when you want to look at preventing things like DVT, PEs, you'll use both warfarin, heparin, and Coumadin, because you want to prevent the PT and PTT, meaning the extrinsic and intrinsic pathway, from cascading out of control. You're going to look at the PT, the PTT, and or the combination, which encompasses the INR, which we spoke about having a range of 2 to 3. So I wanted to review a few of the tests that are done. I used to just memorize these names and really never understood what they did, but they're pretty simple if you're able to visualize it. So the direct Coombs test is when an antibody is directly attached to a red blood cell. Okay, so it's attached to the red blood cell. And what happens is you draw the patient's blood, you're looking for that antibody connected to the red blood cell. It's washed in what's called a Coombs reagent. It's a anti-human antibody, and what that does, if these antibodies are attached, they'll cause them to clump or agglutinate, and they'll cause them to clump, and you'll be able to see them in the test tube. So what we're looking for are autoimmune diseases, congenital diseases, drug-induced hemolytic anemias. So that's caused by IgGs being bound to red blood cells, and what happens is a complement comes along and takes care of those. They're lysed or by macrophages, or they're destroyed. So that's what happens in autoimmune hemolytic anemia. So your own body produces these IgG antibodies, and they attach to the red blood cells. They're marked to be taken out by our immune system. So we can also see if mom's antibodies, a mom who is Rh negative and a Rh positive baby is being born, we can see if on the blood cord if the antibodies are passing in to destroy the fetus's red blood cells. So with the indirect Coombs test, we're looking for antibodies that might be in the serum. So these antibodies can attack red blood cells but are not attached to red blood cells. So the indirect Coombs test is most commonly done to find out if antibodies in a recipient's or donor's blood is present before a transfusion. So what happens is we draw the recipient's serum, we put the donor's blood into the serum, we wait, and we are then adding the Coombs reagent again, and if there have been IgG antibodies that have adhered to the red blood cell, they will clump again and they will cause agglutination. So, for example, in pregnancy, if during the indirect Coombs test there is found to be an RH factor incompatibility, RhoGAM, an IgG, is given to an Rh negative mother to prevent exposure to the Rh positive blood, to prevent erythroblast fetalis in the subsequent pregnancies, a fatal hemolytic disease of the newborn. So it's given at 28 to 32 weeks and given within 72 hours after delivery. Threatened abortions, complete abortions, spontaneous abortions can occur. Abdominal trauma with vaginal bleeding is another indication to give this the RhoGAM. So this is an image of the soft palate and the oral mucosa. So what do you think of when you see this? Now these are already pointed out as petechiae, purpura, ecchymosis. So petechiae is visible in small superficial vasculature like the oral mucosa. The question is the mucosa the only place this is occurring? The answer is no. It is occurring in deeper vasculature, but you just can't see it because it's covered up by multiple tissue layers. So you need to go to hunt to find out why. So keep this in mind as we discuss other disease processes. So if I see petechiae, I know it's a problem in the circulation that is leaking. I can see superficial small vessels, and these capillaries are leaking. So the platelets are responsible for the correction of this problem, and the intrinsic pathway. So are the platelets failing? Do I have a problem with the formation versus destruction? Do I have a problem with the coagulation factors? Do I have a problem with the bone marrow, drug complications, vitamin K deficiencies? Those are some of the things I have to think of. And the purpura is greater than 3 centimeters. That's about 2/3 of an inch. Ecchymosis is closer to a hematoma. It's the pooling of blood. So let's quickly review the components shared in the previous lectures. So as we discussed before, we can use the analogy of a train and train cars in describing the function of red blood cells and their carrying capacity. Their job is to carry oxygen and other nutrients to cells for their function and to dispose of CO2, metabolic waste, and urea. So we can think of the red blood cells, I like to think of them as the wheels on a train car. Their shape is important in being able to move the train along. Vitamin B12 and folic acid. Their nutritional requirements to form the structure for a red blood cell to have the correct function and carrying capacity. The hemoglobin, their structure is very important in determining the carrying capacity of those red blood cells. The heart, stomach, liver, kidneys, they all play kind of a role in either providing nutrients or disposing of waste or producing new red blood cells. As we said before, the plasma, the blood, if you're able to spin it down, 55% is plasma, 45% is formed elements which include red blood cells. The hematocrit is the number of red blood cells that are present in those formed elements. The percentage is usually 40%. We use that in determining the function of red blood cells. Hemoglobin is usually 16 grams per deciliter, and most are what are called hemoglobin A1. 98% are of that type, and we'll talk about when hemoglobin causes problems like in sickle cell disease. So when we order a CBC with manual differential, what we'll do is we'll look at a blood smear. We'll take a sample of the blood and look at it underneath a microscope. Typically what we can see are red blood cells. We can look at their shape, their potential size compared to other cells on the smear, their color, which determines usually how much hemoglobin they have. We can look at pathologies. When we look at ratios, we should see about 1,000 red blood cells compared to one white blood cell. We talked about white blood cells in the other lecture, so you can review that in the other lecture. There's about 1 platelet per 20 red blood cells, and like we said, the lifespan of red blood cells is about 120 days. A mature red blood cell can be differentiated from a reticulocyte because a reticulocyte is a newly formed red blood cell. It can be stained, and what you can see are the organelles within the reticulocyte. So when we talk about erythrocyte indices or red cell morphology, what we're looking at is the red blood cell count, shape, color. We're trying to determine if there's a deficiency in the function of the red blood cell. Remember, we've said this before, any cell in the body is no more than a 2-cell distance away from a capillary. Some cells, such as neurons, require a lot more energy and disposal of waste because they're a lot more metabolically active than, let's say, some skin cells. Anemia is when hemoglobin in the blood is too low to fulfill oxygen demands. Remember, liquid is a poor carrier of oxygen, so we need hemoglobin bound in red blood cells to carry enough oxygen to meet the demands in our blood, of our tissue. So when we talk about MCV, or mean cellular volume, sometimes it's referred as mean corpuscular volume, we're looking at the average red blood cell size. We say volume because I'll tell you in a minute how it's measured. So when you have a normal cell, it's 80 to 100, it's called normalcytic. When it's too small, it's called microcytic, and when it's too large, it's called macrocytic. So if we had to measure the average size of a red blood cell, we're limited to our ability to measure something on average of 7 microns, something smaller than our human eye can detect. So remember, you can count the number by a machine. So what we do is we centrifuge down and get the red blood cells, and then we multiply the volume of the blood that we get by the proportion of the blood that is cellular. Remember, that was the hematocrit. It's on average 40%. And then we divide it by that product by the number of erythrocytes, and that gives us the mean corpuscular volume, or the mean cell volume, and we can tell the average size of the red blood cells. Then we look at what's called the mean corpuscular hemoglobin concentration, otherwise known as MCHC or MCH. When we look at a red blood cell, the hemoglobin gives off a color. The color can tell us how much hemoglobin is contained in the red blood cell. So we look at the percentage by weight, or the average hemoglobin concentration per red blood cell. So if you look at a normal concentration, we call it normal chromic. Chromic means color. If the central power is greater than 50%, we call it hypochromic. If it's greater, hyperchromic, and I don't have one of those cells on there. I do have, however, what's called a target cell. So that's where the hemoglobin is accumulating in the center of the cell, or sometimes you see what's called basophilic stippling, and that's seen with lead poisoning. So if you hear target cell and basophilic stippling, think lead poisoning. So most of the circulating lead is bound to red blood cells, and we'll talk about a little more about this in a minute. With only a small fraction in the plasma, if the levels start to increase, they say more than 60 micrograms per deciliter, the red cell binding is saturated and the plasma fraction starts to increase. So basophilic stippling occurs, in which the ribosomes are taking up the lead, and they're seen on a blood smear. All right, let's quickly talk about anemias, but it is heavily tested on in the hematological sections of the PANTS or PANRAY. So if we use our red blood cells in the analogy as being a train and train cars, it's the inability of this train and train cars to deliver enough oxygen to meet demands, the tissue demands, the cell demands, the organ demands. Whether those demands increase or our capabilities decrease, there's a mismatch. So let's keep in mind the morphology and indices as we discussed in the previous slides, as it is a method for categorizing anemias and other hematological disorders. So the first one we want to talk about is sickle cell disorder. So as you can see on peripheral smear, you might see a sickled cell. It's categorized underneath a normochromic, normocytic anemia. It is a hemolytic anemia, and the reason why is because the indirect levels are increased, and there is an increased chance, as Joe described, an increased chance of having gallstones. So the problem is with a hemoglobin S being produced instead of the A like normal people do. And you would diagnose it with electrophoresis. So there's a genetic variant where the hemoglobin S is created. It causes an abnormal crystallization of the cell membrane. The cell becomes fragile, and the lifespan for a sickle cell is around 20 days. You can see that bumping around trying to go through capillaries and causing damage and becoming lysed. Another hemolytic anemia, it's also categorized as normochromic, normocytic, and it's G6PD. Heinz bodies, analogy that Joe used. Heinz body is a red blood cells where you see that there have been some denatured hemoglobin in the center of that. And you can remember Heinz bodies as Heinz ketchup, fava beans. We'll discuss that in a second with G6PD. So all cells are exposed to oxidation, and the only way that red blood cells have to protect themselves is through this G6PD, or this glucose 6-phosphate dehydrogenase, to protect itself. This becomes abnormal, the cells become more fragile, and they don't live as long because they're not able to protect themselves from oxidation. So some things that there's a Mediterranean variant of G6PD that's precipitated by fava beans. So if you see fava beans, you know what it is. And these can also be precipitated by oxidant drugs such as Bactrim, Septrim, microdantin, antimicrobials, and no treatment is necessary. So the next one, the thalassemia that we want to talk about, is a problem. It's categorized as microcytic hypochromic because it's a problem with the hemoglobin rate of production. There's two types. There's a major form, which is also called Cooley's or beta thalassemia, and there's a minor form. This can occur particularly in Italians and Greeks. The major form, also known as Cooley's anemia or beta thalassemia, is more common in families who intermarry. It also is found in other parts of the globe like North Africa, in Southern Europe, in the Middle East also. So you can see severe anemia in these kids with hemoglobin levels from 3 to 7. And if it goes untreated, you can have problems like massive hepatosplenomegaly, severe growth retardations, bone deformities. So the key note on this one is that thalassemia should be considered in any child with hypochromic microcytic anemia that does not respond to iron supplementation. So if they're not responding to iron supplementation, what you want to do is you want to do a hemoglobin electrophoresis, and you'll see elevated levels of hemoglobin A2 and F. Okay, let's talk a little bit about the homeostasis of iron. You might be asking yourself, well, why is this important? Well, to give a good example, during the bombing raids during World War II over London, England, that was about 1940, 1941, they were getting really good at treating victims of crush injuries. So they would keep these patients alive, and they would be doing better, but all of a sudden these patients would die. Well, they come to find out that what they described as rhabdomyolysis was that these crush injury victims, their muscles were releasing massive amounts of myoglobin. Now what was happening is that the transferrin, or the proteins that are responsible for taking up extra iron so that it doesn't become toxic, were overwhelmed, and the kidneys, they're becoming toxic and dysfunctional because of all this myoglobin, and they would die of kidney failure. So that's one example of why it's so important for us to tightly regulate iron in our bloodstream. So there's about 4 to 5 grams total iron in our body. Most of it's bound to hemoglobin. It's tightly regulated. It's recycled through the spleen. 2 grams of ferritin complexes. Ferritin is a complex that holds iron in our cells, mainly liver, spleen, bone marrow, but it's used for different oxidative processes. And when we look at serum ferritin, it reflects how much storage capacity we have. Are we storing more? Are we storing less? The serum ferritin gives us an idea with that. So another thing that we like to look at is the transferrin. Now that's 3 to 4 milligrams, not grams, but 3 to 4 milligrams. And what that tells us is that measures the body's capacity to bind to iron. Transferrin is responsible for that. And the TIBC is the total iron binding capacity. Okay, how much capacity do we have to bind to iron? And the serum iron, that's the laboratory measure that is the amount of circulating iron that is bound to transferrin. And then we have something called transferrin saturation, or TSAT. Okay, that measures the percentage. Okay, so it's like a ratio of the serum iron and the total iron binding capacity. We multiply that by 100, and of the transferrin that is available to bind iron, that value tells us how much serum iron is actually bound. So how much of our storage or capacity to bind to iron do we have? How much do we have used up? So for example, a value of 15 means that 15% of the iron binding sites of the transferrin are being occupied. Okay? So our bodies don't have a way of excreting any iron, so if we get too much, we're kind of screwed. But we do have a loss of 1 to 2 milligrams per day, depending on our situation. Females, because of menstruation, lactation, will lose more. Remember, we have thousands of micro traumas, the mucosal lining of our GI tract. We lose some blood, and it's tightly regulated by the and recycled through the reticuloendothelial cells. So the only way we have of restoring those is by absorption through our GI tract. So some of the things I listed that we have to think, okay, is there anything preventing us from getting enough iron? One is diet. You got to think of diet. Usually is not a problem here in the United States, but in many other countries, diet, not getting enough iron in their diet. We have a lot of iron fortified foods. Crohn's disease, celiac sprue, anything that causes inflammation, irritation in our GI tract that messes with the function and the absorption of iron can give us problems. So those are some of the things we have. Okay, who am I? So let's say you get some lab values, the serum ferritin is decreased. That, remember, is an indirect indication of the storage capacity that our organs have. There's a certain amount that our organs have. They store them, but we look at the serum ferritin because we can't measure that directly. Next, our total iron binding capacity increases. So the serum iron, the transferrin, our body wants more. So that's starting to bind more iron. The third thing that happens is you start to get microcytic hypochromic, so that there's starting to be changes in the red blood cells, okay? and you see smaller red blood cells, and the hemoglobin concentration is going down. What do you think of? Iron deficiency anemia. So some of the common causes, so this is kind of the pattern. So the serum ferritin goes down, telling us our storages are low in our organs. The total iron binding capacity increases because our body wants more iron, and then the red blood cells, they're the last to be affected. The MCHC, remember, is the mean corpuscular hemoglobin concentration. That will start to go down. So some of the causes can be dysfunctional uterine bleeding, GI bleeding, pregnancies. As your demand goes up, you can't meet those demands, and then adolescents with growth spurts, and that's why we have screening for some of these kids when they come to see the pediatrician. The treatment is ferrous sulfate. So looking at the analogy of a red blood cell and its components being a cart on a train, when we talk about vitamin B12 deficiency, we have a problem with the structure. You're still able to build the red blood cell, but the structure is incorrect. Some of the things that can cause pernicious anemia mainly are the absorption of B12. Pernicious anemia, we'll talk about that on the next slide. Crohn's disease, gastric surgery, you're eliminating the ability to absorb the vitamin B12, or even strict vegans can decrease their nutritional intake of that. So as we said, the train car is formed, so you get a macrocytic, so it's too big. You get a macrocytic hypochromic, meaning there's not enough hemoglobin to carry the oxygen. A common complaint is loss of vibratory sensor, a test that can be performed to kind of lead you in this direction. The treatment is to bypass the absorption and give a shot, and so you know the patient gets that B12. Okay, so who is pernicious anemia? We know pernicious anemia is a vitamin B12 deficiency. B12 sometimes is referred to as cobalamin. They might use that on the test. So who is it? Well, males greater than 50s, they're smokers, they're drinkers. They lack the intrinsic factor, which is a glycoprotein produced by the parietal cells of the stomach, and that's necessary for the absorption of vitamin B12 later on in the terminal ileum. So who told you to stop making intrinsic factor? You did. It's autoimmune in nature. So there's a higher rate of gastritis leading to gastric cancer. The treatment of choice for flare-ups are steroids like prednisone. So how do you detect, or how do you determine whether the vitamin B12, where is the problem coming from? Is it pernicious anemia? So we perform what's called the Schilling's test. Now, I never really knew what the Schilling's test until I looked into it, but it makes sense. So there's 4 stages. With stage 1, you get 2 doses of vitamin B12. The first dose is an oral form. It's radioactive, and it is given by mouth. An hour later, you're given a shot of B12, and then from there on, you're collecting a 24-hour urine sample. So the urine's checked to see if you are absorbing the vitamin B12 normally. If this is abnormal, then you go to stage 2, which can be done 2 to 3 or 3 to 7 days later. In stage 2, you're given radioactive B12 along with intrinsic factor. So this can tell us whether your low vitamin B12 is caused by a problem with your stomach, preventing it from producing the intrinsic factor. If this stage is abnormal, you can go to stage 3. So this stage is done after you're given 2 weeks of an antibiotic to see if abnormal bacterial growth has caused you to not be able to absorb vitamin B12. And then you can have a stage 4. If that doesn't take care of the problem, you're giving pancreatic enzymes for 3 days, and then you're given a radioactive dose of vitamin B12, and that's the Schilling's test. So if you look at lab results and you detect decreased iron, decreased total iron binding capacity, increased ferritin, what is this consistent with? A, iron deficiency anemia, B, anemia of chronic disease, C, thalassemia trait, or D, lead poisoning? The answer is anemia of chronic disease. It's a normocytic anemia. Some of the causes can be lupus, rheumatoid arthritis, CRF. So a range of underlying conditions can cause a release of pro-inflammatory cytokines. These cytokines trigger a change in the intracellular iron metabolism. As a result, serum iron falls and erythropoiesis is retarded, and it causes anemia. Sometimes erythropoietin receptors in the kidneys can be affected. You got to remember these autoimmune diseases, these autoantibodies bump around into a lot of things, and they can irritate a lot of these receptors that are responsible for other things. Okay, so a 55-year-old woman presents with a chief complaint of easy bruising, gum bleeding when she brushes her teeth. She has no personal or family history of bleeding disorders and is currently taking no medications. Physical exam reveals multiple purple spots, 1 to 5 millimeters on the mucosal membranes of her mouth. She has no prior history of such episodes. There is no lymphadenopathy or splenomegaly. CBC reveals a platelet count of 12 times 10 to the third per microliter. All other cell lines are within normal limits. The peripheral blood smear shows thrombocytopenia, but no other abnormalities. What is the diagnosis and what is the treatment? 1. Observation and sometimes prednisone, 1 to 2 milligrams per kg, PO for 3 weeks, then taper. 2. IV, IVIG. 3. Platelet transfusion, or 4. Splenomegaly. The answer is on the next slide. So the diagnosis is ITP, idiopathic thrombocytopenia purpura. It causes increased bleeding due to low platelet count, females more than in males. It can be post-viral, so you can clinically see bruising, petechiae, nosebleeds. It's when a platelet count gets below 30,000, and that prolongs what? Bleeding time. That's because bleeding time is responsible for that primary platelet plug, and if you don't have enough of them, then you're going to see in the capillaries, you're going to see those thrombi there. And the normal range is 250,000, and the treatment sometimes is none and sometimes steroids. The next coagulopathy that we're going to discuss might present something like this. A 40-year-old African American woman with a BMI of 50 with a 2-week history of malaise, fatigue, diarrhea, and vomiting presents. She is slightly confused. There's petechiae on her lower extremities. Otherwise, the exam is unremarkable. Lab tests show a hematocrit of 25, platelets of 10,000. Lactate dehydrogenase is elevated. Serum creatinine is 1.1. The peripheral smear shows fragmented red blood cells, also known as schistocytes, and an elevated reticulocyte count. Which of the following do you expect to see on coagulation labs? So what she has is TTP, also known as thrombotic thrombocytopenia purpura. What's happening here is the platelets are affected. So schistocytes are fragmented red blood cells, and they look something like you see there on peripheral blood smear. As we talked before, von Willebrand factor plays a twofold role in the hemostasis of coagulation. It acts as a carrier protein for factor VIII, and it protects it from being degraded. There's an enzyme that's responsible for cutting the von Willebrand factor to be released as a gap for the endothelia that is exposed. And what happens in this disease is that is not functioning properly. So what will happen is the lack of this function of the enzyme will interact and trigger aggregation of platelets, circulating platelets at the site of high intervascular shearing stress areas, and microthrombi will occur in microvascular system, hence the petechiae. So that's what's causing these symptoms. So the micro thrombi, you think about the purpura, the neurological symptoms, headaches, confusion, blurred vision, seizures, the fever, renal symptoms. So all those things can help. And that's why the bleeding time's affected. So fresh frozen plasma or plasma exchange is very important because this has a high mortality rate, and you better make sure you have a consult with hematology also. The next vignette is a presentation that you might see with our next coagulopathy. A 12-month-old boy presents with a sudden onset vomiting and temperature of 102 degrees Fahrenheit. On examination, the child is irritable, tachycardic, has pallor with cold extremities. There is a diffuse skin rash with abdominal petechiae and signs of nuchal rigidity. Lab tests show leukocytosis, thrombocytopenia with increased PT and PTT, and decrease in fibrinogen. There's elevated fibrin degradation product and elevated BUN with metabolic acidosis. A spinal tap is positive for gram-negative cocci and CSF, and meningococcal is confirmed. So we know this patient has meningitis, is probably septic. So we're looking at what's called disseminated intravascular coagulopathy. And what happens is that this degraded fibrin product is really a D-dimer. It's caused when the scaffoldings created by fibrinogen or fibrin is turned to fibrinogen is cross-links with platelets fibrin, but this is a cascade that gets out of control and it consumes the procoagulation and the platelets. So it's always it's always caused by a secondary underlying disorder. But what happens is your homeostasis for your coagulation gets out of sync because you used up all the coagulation factors too quickly, and then you can't control bleeding. So that's why both the PT and PTT is used up, the platelets are used up, and you have low fibrinogen with a positive D-dimer. So the treatment is fresh frozen plasma, and this is where you'll need a consult, but possibly heparin to prevent blood activation. I would like to thank Joe and all of the time and energy he has put into helping us prepare and pass the PANTS or PANRAE. Come join us at paboardreview.org. Please send your feedback and comments to wes@paboardreview.org.